I want to talk to you a little bit about arthritis of the hip. Arthritis is the loss of the cartilage that coats the end of the bone. There's cartilage that coats the head of the femur. There's cartilage that lines the acetabulum or the socket. These cartilage cells allow the joint to move smoothly, provide a level of cushion per se. But when these cartilage cells die, that's arthritis. Cartilage dies for genetic reasons primarily, but it can be due to trauma. But also be caused by abnormal bone development in the hip socket and abnormal anatomic findings in individual patients that can contribute to the progression of arthritis earlier than just due to primary genetic factors. This is a picture of someone who has lost all the cartilage in the hip, and there is no space available between the acetabulum and the femoral head. Here is one where their cartilage is still preserved. So radiographically, we are looking for this type of hip before we think about treatment with a hip replacement. The way I perform hip replacement is I utilize a direct anterior approach, which is a less invasive approach to hip replacement. We make a small incision in the bikini line in the hip crease in the front of the hip. We then separate the skin and then get to two muscles that we separate. And once we separate those muscles, in retraction, we can see the hip capsule. We make an incision in the hip capsule, and then we can see the hip socket and femoral head itself. We utilize X-ray, and we also utilize robotics in these techniques as well. We make a cut in the femoral head and we remove the femoral head, and so the hip essentially looks very like this. So this has been removed, and through that small incision in that space, we're able to put a liner in the acetabulum or the socket. This is a titanium liner that has a plastic liner within it. It is wedged in position. We confirm its position. We confirm that it's in the optimal position with radiographs and with X-ray while we're in the operating room. We then, through that same incision, are able to place our hip stem, which fits and wedges inside the bone. We then place a ceramic head. We place it in position. We ensure that the leg links are symmetric to the contralateral side, and we do that with X-rays and are constantly monitoring the length during the surgery. With the hip reduced, we then close the capsule, let the muscles come back together, and then the patient generally walks out of the facility the same day. All of our hip replacements typically go home the same day. We utilize a spinal anesthetic. So typically people do not have a general anesthetic. It is a safe means of anesthetic and one that allows for easy recovery. Most patients with hip replacement, we allow to put all of their weight on it immediately. And typically these patients are walking normal within 1.5 to 2 weeks, and by 3 weeks walk into the office with a normal gait without an assist device. That's either a cane or crutches. By 6 weeks, patients are doing most of what they want to do, certainly are playing golf, taking hikes, and by 8 weeks are doing everything they want to do. My patients ski, they hunt, they scout for elk in the mountains, they helicopter ski, they backcountry ski, Nordic ski, fly fish. There's very little that you cannot do with a hip replacement. It is one of the more successful operations we have. It allows people to get back to work, improve productivity, and generally have the highest patient satisfaction of all of our orthopedic procedures. When I perform a hip replacement, I utilize a direct anterior approach. This approach has two advantages. One, there's no damage of the muscle, there's no cutting of the muscle. We separate between a fascial plane between two muscle groups to access the hip joint and perform the procedure. The other advantage is that we are able to utilize X-ray throughout the procedure. It allows us to get the leg lengths perfect and the component positions perfect. In addition, we often will utilize robotics that allow us to perform the procedure in exactly the same way, but utilizing robotic techniques to ensure the position of the components and leg lengths as well. Either way, we utilize the direct anterior approach, which is a muscle-sparing, non-muscle cutting approach. The great thing about the way we do hip replacement is that many of our patients do not use narcotic medications. Not only are they putting all their weight on the hip and walking early and normally within a few weeks, they rarely require more extensive opioids. Often aspirin for preventing blood clots, an anti-inflammatory, are all the medications that are necessary in recovery from this procedure. After hip replacement, we do offer the opportunity to do physical therapy, but often patients do not need to do so and often do not utilize it.